Thank you. We give you a. You can start now. Thank you.
Okay. So the title of my talk is it's kind of initial step or a part of a two-step analysis that I'm working on, and this is titled Ethical Analysis of Prescription and Illicit Drug Overdose for 3 states: Arizona, New Mexico, and Colorado. I'm really interested in doing a 4-state study, so this is just the first step, and once I've collected enough data for the 4th corner, which is Utah, then I'll go ahead and incorporate that in the study. So this is just kind of an initial analysis of prescription and illicit drug overdose. Okay. And again, I'm from the University of New Mexico, and I'm also a fellow with the Roybal Johnson Center for Health Policy at the University of New Mexico. So the first part of this study is just to kind of examine the risk and protective factors of drug overdose for these states. And again, I'll extend it to the 4th state. But what I'm really interested in is how does social environments, the social context as a sociologist, how these different environments, or what we think is impacting these elevated rates of overdose. I'm interested in overdose, but this could be any type of, so it could be a suicide, it could be other types of mental health issues or things like that. So I'm looking at why the environment or how the environment impacts, it's particularly these states. The second part, we'll look at the role of policy reflecting, like inclusive policies, the health expenditures, why, I want to know what within those environments are causing this overdose, and can it be addressed at that level? So who receives treatment and how inclusive are we in our healthcare systems, right? What is an addict, who determines, and how that's divided among different populations. So certain particular populations have different health outcomes based on, and I look at it by race and ethnicity, right? We have this, so I find this of particular interest. So kind of the background, I just want to look and give like a broader scope of what overdose looks like in the United States in general, right? So this is 2013, and this is a round off number. It's probably about 43,000 deaths were reported in the United States to drug overdose, and this includes prescription opioid as well as heroin, which is a very small percentage compared to the larger prescription and other illicit drugs. And the reason within this study, I'll explain a little bit more how I measured everything and how I combined them and why I did that. But this is kind of an overview. This is right after traffic accidents. More people die of overdose than actually traffic accidents, which I think is astounding, right? So drug overdose, it's doubled from 1999 to 2013. So overdose deaths is largely doubled. 81% of all overdose deaths were unintentional. So whether the person is a regular substance user or whether they're using it to control pain, it was unintentional or deemed unintentional. This data collected from the CDC. And this is a very interesting, so an estimated $55.7 billion was spent in prescription opioid costs. So this is treatment, medical emergency room, treatment, criminal justice costs. So this is just an estimated factor, and it may be even higher. So it is a big economic burden as well. So these are the overdose trends from 1999 to 2009. And you can see as they increase, it's not very clear, but these are some of the higher. The red is your elevated, right? It's broken down with population, but I'll break that down a little bit better. So I'm interested in this area down here, which has consistently been high. So these are the 4 corners region, or 3 corners, right? New Mexico, Arizona, Utah, and Colorado. The analysis here only covers 3 states, but this is kind of, you've seen like this trend has existed. This is 1999, but when you're looking into the historical records of overdose or drug overdoses, in New Mexico, we're looking at high elevated rates as early as like the 1900s when morphine and other things, opium, started to come in and be distributed through medical practice and illegally, right? So these are poisoning deaths, same thing. This is in 2008, and it's just a clearer picture. So this is the areas that I'm looking at, and if you compare these areas to other parts of the United States, you can see where different areas overly stand out. So I'm in particular interested in right here. So I'm using this particular theoretical framework, which comes from Durkheim. I'm a sociologist, everything is based on this type of theory. And with this, his social theory was of suicide. And so it's looking at how those factors outside the individual, the environment, the community, the neighborhood, the state, whatever social context, how that impacts the individual. So you would never see an individual, a child, 8 years old, I'm going to wake up, mother, in 15 years I will be a full-blown heroin addict, or I will be committing suicide. So no, there's environmental factors that go along with these individual level factors that create these environments that are conducive to things like overdose or suicide or different mechanisms. So his theory is a social integration, and social integration is the degree in which individuals feel connected to people within their group or community. So how those things play out and how these structural things. He argued that suicide wasn't an individual act, like as we would think, as the individual walking out, I'm going to commit suicide. There's so many other factors, community factors, and it's also kind of a measure of community health, right? So when you have these elevated rates of infant mortality or suicide or different, it's talking about the community at large. And so this is kind of where this framework that I'm coming with and looking at it. So what I did in this study is I started collecting county level data for these 3 states, and now I have 4 states. So what it means is I collected every single incidence of overdose death for the 4 states for every single county and built a data set, basically. So through vital stats and all these different records that I'm working with right now, they send over their every single measure or every count, death count, right? So the data is also collected from the census, the historical geographic information system, the Bureau of Economic Analysis, and I'll show where where this is going actually, Center for Disease Control. And then what I do is I model the death count itself, right? And there's specific types of regressions for different types of numbers. But I really look at count, because count is the final. It wasn't a person that came in and that actually they overdosed, they were saved, and then they went home and they're back in the system. These are actual count, death counts, which is very final. And I guess that's kind of why I'm interested. There's a specific model for looking at counts like these and other health counts called the negative binomial. So I created a model that looked at all these other environmental factors so I can kind of decipher, determine, or look at where I want to take the study. So this is really small, but I'm going to break it down because it looks complicated, and it's really not. So what this is just a summary statistics of the different measures that I put in there. So I looked at educational attainment at the county level. Educational attainment, you'll see lots of arguments. Education is the key to this. The low levels of education are why we have higher overdose rates. And my model says that education is not significant. It's not significant we'll look at the actual, I'll show you the actual model itself and break it down. But let me back up a little bit. So I had 112 observations, so 112 counties between these 3 states. I looked at unemployment. We've all often heard that unemployment, as unemployment rises, maybe overdose would increase or different things like that. Poverty is one of the biggest arguments right now. We have high poverty levels, therefore we have high levels of suicide or overdose, right? As the young male population increases, males, if you look at the stats, you'll see that males are more likely to die of an overdose than females. So I included that in there as well. The other argument is that rural counties are responsible. They're rural, so therefore they're going to have higher levels of negative health outcomes such as this. And then I also control here for the white population, percentage of non-Hispanic whites living in each county. I control for the percent of Hispanic population, also for the percentage of African American population and American Indian population within each county. And this really important factor here is I included an index for social capital. How high are people integrated within those counties? And so these are the basic measures and variables that I added in there. But I want to back up and look at the actual overdose counts. So the average overdose for counties was 88. That is the average. 88 overdoses. okay? The highest is 2,800 overdose deaths within one county.
Wow.
Can anybody guess where that is? What state? So Colorado, New Mexico, or Arizona?
New Mexico.
What is it?
New Mexico?
I came into this study thinking New Mexico. New Mexico is known as the heroin state, the overdose capital of the United States. And it's something that's projected and talked about in the news, in kids, within schools, but I failed to believe that. I also heard an argument that it was a cultural thing, that intergenerational heroin use was the cause of all of these elevated rates. So I wanted to investigate this and maybe even debunk this myth, because I just don't believe that this is a cultural phenomenon, right? This county, 2,800, you're standing in it. Scottsdale, Arizona, Maricopa County, all of this right here.
Wow.
Arizona.
Wow. Wow.
So it is not, right, that alone, right, in the summary, kind of debunks that myth and points that direction. So I'm curious, like, okay, this is different and this is interesting. So this is the actual model. And it looks like little numbers, but I'll explain it very easily, right? So when I went through it, I found that education was not significant. Educational attainment in this case was not significant, right? It was positive, which is fine, but it had no significant things in what is it? Impacting, supporting, or decreasing overdose. Unemployment was not. Poverty was not. So I'm starting to get a little. Young males was not. Rural counties was extremely significant. But it's a negative significance, meaning that as rural counties decrease, so does overdose. So this started to strike me because the myth is that it's a rural, it's actually an urban. So it's urban counties, right? So I'm thinking, okay, that's interesting. The Hispanic, this is not significant. Percent Black is not, percent American Indian, but the social capital came back very, very significant. So social capital decreases, overdose increases, which is a really significant finding, and people have found things like this with binge drinking, alcohol use, and other types. So as social ties disintegrate between individuals, then you see these elevated rates. Social capital has a potential to mediate poverty, unemployment, and all these other factors that we have known. Does that make sense? I would mediate that. And this is just a way of, a nifty way of describing these coefficients. So this is just an incident rate ratio, and it's just a way to talk about them. So for every unit that social capital decreases, overdoses of prescription and opiate, prescription, opiate, and illicit drug overdoses increase by 0.5%, and this is extremely significant. So that's kind of what that. So this is the first part of the analysis. And I'm not going to read through this, but that's basically looking at how rural populations, as the rural decrease, urban populations increase, that we're seeing more of this. Social capital, it's very significant. I went ahead and took the 3 states and put them in a graph so we could see how social capital works within them. And this outlier right here, that's actually Arizona. So Colorado and the state of New Mexico are hand in hand. Same thing as social capital. So this demonstrates this overdose death counts by social capital. So for these 2 states, as social capital increases, overdose death decrease. So we kind of want to know, pinpoint, what's going on within this environmental context. So this is like the first part. Does everybody know what social capital is? More or less?
No.
Okay.
Please
So
explain.
and for this reason, I put a little to talk about social capital because I find it's really fascinating. So I'm interested in, to what extent is social capital associated with drug overdose in these counties? I wouldn't have thought this as a high-risk county, but yet it's the highest for that. So what is going on within there? So I'm looking at social capital describes the benefits that are derived from personal social relationships. within families, communities, and social affiliations. Social capital is one of the indicators of social integration, which I talked about how well people are integrated within communities or at the collective level, at the community level. It also refers to the features of social organizations such as networks, norms, and trust that facilitate action and cooperation for mutual benefit. So extant research has established that there's a clear connection between health and social capital. So how well you're connected within your community, do you vote, do you have church groups, do you participate in high school affiliations? How well are you involved in that community? And how the impact that has on health. Because right now what I'm seeing is that the lack thereof of those types of networks and associations is related to overdose death. So this kind of, here's another quote related to social capital, but I'm interested in what is inhibiting people from being integrated or socially integrated within the urban setting, right? We can look at where we're at, right? We're on tribal land. How well integrated is this tribal with the rest of the community here? How well integrated and how are these networks? Are they socially inclusive? Are they inclusive by with other communities, or are there racial divides? Is there segregation? Is it an economic or a class divide? And how these things are impacting. So this is kind of leading into the second part of my study, which I'm going to ask everybody to kind of help out. This is a little, I guess I need more feedback looking at the ethical, and what other ethical questions that we could ask that could be integrated into this study. Like, why would that impact, and who's receiving services, and who is dying of these different populations? It used to be that African American males were at the highest rates, but that is not the fact anymore. It's actually non-Hispanic white males that overdose at greater rates than other populations. So there's a complete flip, and there's something going on. And so looking at, are these populations or people that become addicted or different things like that, are they stigmatized? Are they giving access to service? Are people more dying in New Mexico because there's lack of treatment facilities? Where are these treatment facilities being placed? Are they privatized? Should the state include? So there are other states where the counties are different. They teach the police to provide packets of Narcan or different things like that to help with overdose. But that's not everywhere, and that's not inclusive of everywhere. So this is just kind of like the beginning of the study and a beginning point to kind of look at. So it's going to be interactive.
So were you able to gauge how, with the social interaction and integration of people with their communities, were you able to take a measurement of how much participation merits social integration, and that would keep them more healthy and away from overdosing?
So it's interesting. So I use an index, which is created by So there's 5 or 6 and they're famous, they're well established, and they're used for a lot of different, and I have those, that data, so we can look at it per county, right? And what they measure. But I almost go for what is social cap. So by dissecting the population and knowing which parts of the population are affected and how, we can better measure what types of social capital and how maybe would we invest in things that integrate communities rather than investing in other types of, or policies that would create a more inclusive environment. Because you do need to measure, and I think that social capital means something different for different populations, right? So social capital for a Hispanic immigrant population is something totally different. It might have a hint of the same type of social capital we're talking about here that they've used nationally, but there's never been a measure created for racial and ethnic populations. And to know at what point would that be. But what it means is you might have a friend who helps you get a job, who has access to resources and information, who knows somebody that can get you into a treatment facility, or who has, it's about making those networks, those connections in order to get to a healthier. Because the majority, if you do look in, you break it out with per county, per state, and you look at, you'll see how different populations, like in New Mexico, there's maybe 3 or 4 there's no major treatment facility north of Albuquerque, Santa Fe. I think they built one recently in Santa Fe, but you can literally map them out and you can see where they're placed, how they're placed, are they privatized, are they, and you'll see those populations. The curious one to me is actually this county here, right? How is social isolation, or how people are so isolated within, such a there's a lot of wealth here, there's a lot of different, and then what types of things. So I can actually break the data out by type of drug, and I have some ideas to why, what's impacting it, but.
Have you looked at it within this area, by breaking it down between the Native Americans and then the general population? Because I assume it's all inclusive.
The majority, I brought looking it down, and I've actually controlled for certain populations. When you remove social capital, then it does become significant for the American Indian population as well as the Hispanic population. So the presence of Hispanic populations within that context will show higher rates of overdose. But it's actually not the Hispanic or the Native population. It's non-Hispanic white males within that.
Yeah.
And they're largely because of prescription opioids. Other populations may not have access to insurance or to other things that makes them have a closer. Does that make sense?
Mm-hmm.
Yeah. It's interesting, and I'm looking forward to moving forward with this study and kind of dissecting it and looking at all the different, how this would mediate for those populations. Because once you remove it, and you remove it in like rural communities in New Mexico, then you do see elevated rates. Why? Because there's no access to facilities, there's no access to treatment, there's no access, and the majority of the population, a large percentage, over 60% of the population in New Mexico are not insured by health insurance. So it depends what types of narcotics. So I'm actually collecting a lot of data right now on what types of narcotics come through, what's their content, but the majority, I have some other statistics, but the majority are from over-prescribing from physician actual. And so there's an actual number, and it basically says that everybody in the United States, so much has been prescribed that everyone in the United States has, it's like the equivalent of everyone holding a bottle of opiate, 200 pound quantity across all, it's like that's how much. So obviously not everybody has a bottle of opiates, but it's out there in circulation. So.
There is, maybe I missed it when I started my hearing, but anyway, there's one other issue that you may have covered. It's always kind of bothered me in drug overdose. Have you looked at religious commitment?
Yes, in certain contexts, yes.
It's part of social capital, is there? But,
yes. Religion is a huge part of social capital because you have so many networks by being part of some type of faith community or religious community, faith community.
Very strong.
And
very
so
strong.
that does, and that's actually in some of the places that I've looked, that's the only access that individuals have to treatment is through faith-based communities. So they're some of the only communities that allow other types of treatment other than medically assisted treatment, which most people can't afford anyhow. So it's actually the faith-based communities that are actually taking people in and helping with rehabilitation and facilitating that for them. Commitment to faith-based doesn't have the same, I'd have to look at it for different populations, but it doesn't, from what I found, it doesn't have the same, it's not a protective factor for American Indian populations, we've not found. I've also found that in other studies that it's not for that and for Hispanic. So we still, even though they're largely percentage and you can control for that, Catholic or whatever different, it's not the protective factor. But those faith-based communities are part of the big recovery, people actually integrating and reintegration of substance users or addicts.
That's very interesting. It is not a protection.
It is not a protection. Yeah.
So that's what normally there's a myth.
That is a
myth. If you are
myth.
religious, then you don't overdose. That is true at all.
Yeah.
In fact,
And
there
the
is-
same for suicide. So I did a large suicide study, and that's the same finding that I had, that for non-Hispanic white, it was a protective factor, and it's largely published in the literature to look at being part of these communities. Actually, Catholics had higher was more protected than Protestants. That's actually part of their kind of the most famous suicide study, right? So I was like, well, I'm going to try this for these populations. Does this hold? And I did not find that. It's not a particular factor. And it's really hard to dice out and separate for other populations whether that's. But that was interesting. That was a really interesting finding. But as far as reintegration, that is one of the only avenues that people have right now in impoverished areas, is those communities.
I just had a comment, well, a question as well. I believe that in Native American communities that the social capital is definitely a factor.
Yeah.
And I think so because our whole way of thinking has shifted from a holistic, family-oriented view to more of a individual, like property owners and the American dream, pursuing this individually than it is collectively as taking care of the family, how it used to be. And I see that not only in my community, but in many Native communities. So I definitely think that social capital is a factor. But I do have a question. When you're talking about, the drug overdose, I'm curious whether in a state that has legalized marijuana, if it is dropping. I'm just curious.
I am too. So I can actually measure it from when like Colorado legalized for the state of Colorado. I can actually look at it. I don't have it done here and I haven't ran it, but I could take, the dates predating legalization and then after. The only thing that you have to think, so these overdose rates are from the years 2005 to 2010. So I aggregated a 5-year block of all overdose deaths within that time period. And whether it was maybe I think the factor possibly or something worth investigating is how maybe the legalization of marijuana has mediated the use of prescription opiates. So rather than using prescription opiates as a pain treatment or as a, maybe using legalized because that's one of the things that people, talk about using it as a pain for cancer, different things. So maybe that's impacted that. But technically, if the state or people reviewed within that time period, it probably would show up specifically. But it'd be interesting to see if I can.
Have you found, well, maybe you haven't done this already, you measure it or a correlation between unemployment and the increase of
So
Is that significant?
So unemployment was not significant. Social, which is, here, let's see. So I did county level unemployment, but as unemployment decreases, it's not significant. It's close, but it's not one of the predictive factors. But it's negative, meaning that if unemployment decreases, and then it goes the other way.
And that's for the general population?
Yeah, and that's per county, yeah.
Per county? Have you done it specifically for the non-Hispanic male population?
I probably have run it, but I don't have it on here. I don't know it right off the top of my head. So for the non-Hispanic, so for like the indigenous populations or what?
Well,
how are you-
because I'm understanding that the non-Hispanic and whatever it was population that's increased, that's the highest right
Yeah.
at this moment in time.
So how unemployment would impact that?
Yeah.
If unemployment
compare.
usually impacts, unemployment usually increases it.
Yeah.
Okay, this is something that's really interesting. You brought something to mind. Is that, I don't know how to make this bigger.
Yeah.
Okay.
Yes, please make it.
So that brings up an interesting fact, right? So for non-Hispanic whites, yes, unemployment does have an impact, right? It increases for suicide. We know that. There's tons of extent research that says that. But when we're looking at these other populations, Hispanic and Native populations, you've had large and historically high amount of levels of unemployment. Do you see that? Probably. And so unemployment and these different things affect it different. Does that make sense? So it's worth actually cutting it and looking at it that way. I could probably do it when I sit back down on the computer. I'm just telling you. Yeah.
It's a very interesting study.
Yeah, it's interesting. And it changes a lot of the myths or the different things. And then kind of a point is to how do we plan intervention and how do we look at prevention? And is it worth, or do we invest more time and energy and money into facilities that create community within these communities or that socially integrate, right? Or these different, do we invest more in that or something in that or look at that, change the angle versus, because there is a lot of, most intervention, prevention, different efforts, they have maybe an individualistic or, how do we affect these individuals with this? This is an individualized treatment. This maybe change the focus in combination that may focus things on the community or collectively. How do we collectively create healthy families or things like that prevent in the long run, right? How do we fruit time? How do we take indigenous communities and reinstill other types of values, norms, and things that have been raised through time in order to build healthy communities for that? And then this tells us who and what, so it's kind of interesting. Well,
Would you wish, repeat again, what percentage of the overdose deaths are intentional?
20%. Unintentional reported are like about 81% unintentional.
Okay, but is that high?
Yeah,
What type
it's
of-
that high.
What type of drug used as a overdose?
So okay,
Is
so
it antibiotic or?
So
other
this is,
drug?
no, this is interesting, because I specifically did plan this to where, okay, so here my summary. So this includes all prescription and illicit drug overdose. So prescription meaning opiate, pain pill. Illicit is any drug that wasn't prescribed, that's considered like a narcotic, a drug. This also includes methamphetamines, heroin, any type. And the reason that I combined them because I can run it and I can split them apart. And it's gonna look very similar. Because when I started looking through the data, I can, to be very specific, cut them and look at them, how the percentage of what is heroin or meth. Those percentages are so small compared to prescription opioids. And they found that in the majority of OMI reports that drug within the system
Yeah.
were always in combination. The majority had a combination. So if they did take care, they also had prescription opioids. So it's really hard to kind of tease that out, but they do find that in the majority that there's a combination of drugs like that. And so I chose to include them all. But yeah, you can definitely, but it's usually, the majority is prescription opioid.
I can give you some suggestions.
Yes, I would love that.
Well, this is where you may want to also check your thesis, whether it will be correct or not.
Yeah,
Correlation is not causation.
yeah.
Factor. Might be the case though. Social capital could be a factor. But you have to show that in some way, some kind of case studies and community focus groups to make the case stronger. And the second one, outcome studies are very interesting. Boarding alone, finding social capital in America is decreasing because of various factors that are mentioned, especially related to economic factors, economic development. You have taken a very interesting case, that's why I'm excited about this. It's very, very illuminating voice. But then the question is it related to, you said that it's not just individualistic, but it could be communities, or what families are affected from this? Maybe the whole family is taking drugs. So that's a very interesting finding for you. So normally we'll think that it is alienated, single men, that sort of normal thinking, right?
Yeah.
Or unemployment or various other factors. So that we have something here quite interesting.
Thank you. I did,
I'm so sorry.
oh no, I like it. I love it.
I just keep reading my.
And I think
How about
suggestions
identity?
helpful.
Was there any correlation between those who were more Native or more Hispanic and stronger sense of cultural background?
No. Basically, these categories were taken from what you would mark on the census. So there is actual data out there that's like self-identified, some are self-identified with American, or Hispanic, and there's different types of data like that. This is directly just from the census, how somebody would check. And because those things are thought to be a buffer. You know, the stronger you identify with this population may be a buffer to these other stresses that cause this type, but not always. And that's what's so striking about it. For not all population, a strong identity. When I looked at it in suicide studies, it did not show as a protective factor. In fact, the stronger, I measured by language. So the population that spoke their traditional language had increased levels of suicide. Why? It's interesting. Why? Because when you speak in 2 languages in the United States, and you come into an education system that only speaks 1 language, your integration levels are going to be, it's going to be much harder for you to integrate. The more traditional you are, language and different, the harder you have to assimilate and integrate within a thing, and that is a big stressor.
Absolutely.
Does that make sense? So there's a threshold, there is a point that you have to look at that, for that fact.
I have a question I brought with the computer by
sure.
Shahanas one of our students in Bangladesh, and she made a comment. Do you want to say it now, Shahanas? Shahanas, can you hear me?
So many
So she
cases
said-
will be found in Bangladesh.
You can talk now if you'd like to Camilla.
Many cases here in Bangladesh also like an overdose, but actually nothing happens to the doctor, you know. In fact, my father died in this kind of cases, you know. He was chronic renal failure, but he was admitted for angiogram, and then due to the diet overdose, he went for acute on chronic renal failure, and ultimately 2.5 months after he died. And it was disaster, you know, and nothing happened to the doctor. So
Where was this?
that's one.
Where
This is Shahnaz, Dr. Shahnaz from Bangladesh.
I see. So nothing happened to the doctor in Bangladesh?
Yeah, nothing. And he said...
Is there provision for something to happen to them?
Nothing happened to them. No,
But
no,
is there
nothing.
a system that if he does something wrong, something should happen?
Yeah, there's no system, you know. This is why I was trying to say that here the healthcare community, they don't really have those kind of accountability. So many cases like this happens. It's not only related to my father, but so many cases I hear and I see, but really the doctors doesn't bother. Nothing really happens, you know. There should be something, you know, like, I don't know what to say.
Right now in New Mexico, I'm working on, it's called the Opioid Accountability Summit. And so we're working with doctors, MCOs, like the DEA, the jail, like people from the criminal justice system to create accountability, you know, for overprescribing and how many, you know, so that brings up a lot of issues as well.
Can I ask a question? Let me ask Dr. Lee. Lee, isn't there a provision when the government is the single payer that there's a medical malpractice restriction against the doctor, where the government is providing the medical care?
Is there?
That's a case
Yeah,
I
think
know
about
about
That
Norway.
is, there is for single,
Yeah,
Yeah, for single payer.
yeah,
that's true.
Right, exactly. Illegally, that makes sense. It would make sense to most lawyers. Because I would suspect it'd be the same way in the United States if that ever happened, because there's a federal tort claim that you cannot sue the government without permission of the government. So if the U.S. ever became a single payer, there would be a certain degree of governmental immunity for malpractice that physicians might engage in. Norway has it, and there's other countries too, where the government is the single payer and provider of health care. There's a degree of governmental immunity.
In New Zealand case, they have a universal accident compensation scheme to replace malpractice claims, so that you cannot sue the doctor. Of course, the medical council can deregister doctors, so there's accountability. But any person in New Zealand who has a certain accident will receive the fixed compensation. It doesn't matter if you're from Russia or America.
So this,
Whatever citizenship you have, if you lose a finger, this finger you'll get so much. And it's a universal accident compensation, and the idea was to eliminate expensive legal suits. But the doctors will still try and defend themselves from being struck off the medical register. But and Sweden was looking at the New Zealand system, and in fact Japan was at the time too, as an alternative to legal malpractice.
What happens in Japan with malpractice, physician malpractice?
There's lawyers can sue, it's just not.
It's recent though, isn't it?
It has existed in the sense there's been a way to sue, but not many people take it up. And there's no immunity, it's just not a culture of legal suits.
so I'd like to also, I mean, even though this is looking at community county, but the policy level, right? Like what policies are in place, how many have passed, how many have used, how we protect, or how this is, you know, how that affects the, this type of thing. So I did a suicide study before this, and it looked at social policy and inclusion through policies, but looking at tribes, because tribes are located within the state context, right? So they're binding slightly to the state law and then also the federal. So they work within this environment. And so looking at how those policies or how voting at the national level affected the tribes. And literally, as changes through administration and political ideologies change, political ideologies impacted suicide for American Indians and Alaska Natives. So these type of things I'd like to look at in Overdose as well. In 2004, voting for Bush increased suicide for American Indians by 13%.
Increased what?
Suicide for American Indians by, like, roughly 1 unit increase in voting, increased suicide by 13% for American Indians. And we're like, well, how did you make the connection, or why would you think that? Why? What did Bush do during that administration? They cut IHS. But there's so many different things that trickle down. So policies at that level do impact lives at these levels. So it's interesting to look at that also. So I'd like to do something like that, looking at policies or different things, accountability, and at what levels, because there are state restrictions or federal restrictions that goes all the way up.
I guess you have to be very careful with causation.
Yeah.
You know, you have to be very careful that it's not a coincident mathematical phenomenon rather than a causation.
So you have to control. There's a lot of different controls and different things that you can put in to read that out. To see if there's, what is it
Yeah.
that? This is like social capital, and this includes, this is a principal component, which means that there's about
Yeah.
30, 40 different items that are
Right,
collected
right.
for each county. How many healthcare facilities, how many daycare, how many, those are just facts. Those are just things they collected from that and become with it. So it controls for all those different little tiny within that. And there's different measures of that, but pretty well known. So nothing that I've used here hasn't been used for other studies. And it's been used, controlled, and shown. So it's not, you know, just taken out of.
Well, from a medical standpoint,
Somebody this is used for social capital.
Oh, the Social Capital Index is from Penn State University. They have a large data bank where they collect social capital information for different years, 2000, 2005. And this is their index. And that index that I used, so it is based on Putnam's, who's like the, so social capital starts with Marx, Bourdieu, Putnam, and then this is the index that's derived from Penn State in order to capture those things that they. So it has a long history of research and different things. It's not, I came up with it all. I wanted to measure, you know, they use these for other measures and develop. So these are from PINS, this is all census or geographic, it's not. And I wouldn't say this is a perfect causal direct connect, but this is something to look at, you know, to give future direction. And then maybe look at, see if there is a causal mechanism and why, and what would that look like?
so from a medical standpoint, there also is the issue of that line between pain control
Yes.
and too much
It's
drug.
a
And it's a very
condition.
fine line, and it
Yeah.
varies in different parts of the country.
Yeah.
For instance, in Oregon, they're not nearly as hesitant to prescribe a lot more drug up there because it's not an issue.
Yeah.
A euthanasia type of overdose is perfectly acceptable by legally and morally, ethically up there, because that's what they've decided.
That is a huge argument right now, right? Who should have pain meds, how much pain meds, how much, for chronically ill patients that have different types of, and that is a question right now, that is, what's too much, but at the same level, drug, opiate, they have their own components, like their principle, it's never gonna change. So at those levels, how they react with the maybe warnings, or, I don't know what the answer, but there is a threshold, and it does not change, and it will never change, and the body can only withstand. So that has to be looked at that level, and it should be. Because 26% of all prescription pain opiates will become addicted to heroin, and that's a statistic, 26%. So there are
26% of what?
opiate pain will have they will start to become full-blown heroin.
So,
The majority of full-blown heroin addicts, actually I looked up the stats and show it to you. It's interesting because you have a lot of people that had a broken arm or a different thing early on. They had opiates, they developed an affinity, they get kind of like a for this, and later on the pain med becomes, they become addicted without even knowing it or intentionally. But it's a lot easier, I don't know how much, but there's a large percentage that they become full on heroin after.
yeah, so the interesting thing there would be,
Unintentionally, it's just,
the interesting thing would be for how long
yeah.
were they on the opiates before they switched to heroin?
Exactly, and cost-wise, were they able to access payments for this, and then it became, I work with a lot of people that have heard, and it's interesting. In fact, some of the accountability summit that I work on for Bernalillo County in New Mexico, one of the heads of that became addicted to prescription opioids. He's a medical doctor, he had surgery, and through his recovery he became, it's common.
Isn't that so?
Yeah. So it's not, it's a composition. So we do have a lot of, it's an interesting question because we have a lot of younger individuals who have already tried heroin at that extent, and that's probably, my guess is that a lot of them started off with a broken arm, going to the doctor and getting prescribed Tylenol, 3 or different high, I don't know, codeine, moving out, transgressing. By the time they're 18, 19 years old, there's actually like a whole coalition of parents that have children who have already overdosed and died and part of this organization. But the guess was that they had started out on prescription opioids and then moved up to heroin because of that age, where are they going to access opioids? Is it from a cabinet? No, it's easier on the street. And then what's on the street is not clean. And then there's no treatment and stigmatization on that. So it's a lot easier, first a kid, like, I'm addicted to, where do they go? Who do they talk to? Where do they get treatment for it? What does the treatment look like? Can their families afford it? So there's a lot of different things that go. There's so many different questions around this whole study. I find it really interesting. Is there any other? I think I went way over my.
Any other comments?
Is that okay, guys?
Very, very, really excellent.